Well, it's interesting to follow Chris's talk because I think that's a very important area of discussion. Spine is certainly an interdisciplinary area. I was actually stimulated to go into spine surgery because of my exposure to spinal cord injury, and I think that we've seen a significant evolution in the way spinal cord injury is managed. The trajectories of outcome are shifting, and we're going to be witnessing further changes that are going to be occurring. So I'm just going to try to give you a little bit of a sense of that, and also kind of talk about where are we now, where are we going. So I don't have any disclosures that are going to necessarily impact the content. I have spun off a biotech company, which is kind of being managed at arm's length. I'm the principal investigator on a few of the clinical trials I'll be talking about, and these are peer-reviewed sources of funding. And big thanks to Jens and to Rod and the other organizers. And would love to be there in person, but at least can participate through this virtual forum. So this is where I work in Toronto. I work at the Krembil Neuroscience Center, which is part of the University of Toronto Spine Program. And we actually have an integrated spine program at the university, which is viewed as kind of a model of collaboration. And be happy to talk about that at some point. And I have an amazing team of people that support me. So spinal cord injury is very heterogeneous, but here I'll present a case that I've looked after, probably one of the most devastating forms of cervical cord injury, namely complete quadriplegia after a cervical cord injury, young person with the C4 Asia A complete cervical cord injury from this bilateral facet dislocation at C4-5. And so what's our treatment approach to the modern era? So I'm going to cover three areas. So I'm going to talk about the fundamentals of acute management, some of the critical care principles, but I'm really going to focus on this concept of time as spine, and that timing matters. Early decompression is important. And I'll reflect on a few areas where we're going to be going. In terms of hemodynamic management, I'm going to try to provide a bit of a recalibration on methylprednisolone. I do think that there's a role for its use, particularly in people with cervical injuries, incomplete injuries. And then, what's going to be emerging in the post-methylprednisolone era. And then I'll be talking about where are we going. So with regard to regenerative approaches, and also an area that I think is actually going to be a new area of specialization, which is going to be the confluence of functional neurosurgery and spine surgery. And this is going to be seen in terms of certain technologies such as epidural stimulation, brain-spinal cord interfaces. So 3 learning objectives from my talk. So one is to understand the concept of time as spine and how it's applied. Secondly, to have an understanding of some of the current neuroprotective strategies under investigation. And thirdly, to be able to at least discuss some of the key concepts related to regenerative strategies for spinal cord injuries. So in terms of early management, a fundamental principle here is time as spine. And the idea here is that early neuroprotection mitigates secondary injury mechanisms and enhances outcome. And this really forms the backbone to a multi-pronged approach to care. So here we've got our patient. So it's bilateral facet dislocation. This is an MRI. And if anybody thinks that, secondary injury doesn't exist, look again. You'll see that there's increased signal on the T2 weighted images extending well above and below this area of contusion compression. So what does this actually, this MRI actually look like? And this is an image, fortunately not of this patient who survived the injury, but this is from Rauschning's a collection of remarkable post-mortem images, but it's almost an identical image here. So it's a bilateral facet dislocation, severe injury and disruption of the disc, marked instability, cord compression, there's a contusion of the cord, and you can begin to see a sense of some of the vascular disruptions that is occurring. So this is now animal model work. So this is a work that I did as a Ph.D. student working under Charles Tatter. It's a microangiogram of an acutely injured rodent cervical cord. This is the anterior sulcal vessels. These are the vessels that are in the gray matter, and there's a mechanical disruption. This is primary mechanical injury, and there's hemorrhage. And then surrounding this hemorrhage, there is this loosened area. And this is the ischemic penumbra zone. And in this zone, there's a progressive degradation of nerve fibers. And this is what this actually looks like on a confocal image from animal work. So these are images fluorescently stained for a neurofilament protein called NF200, and this shows progressive degradation. So this is secondary injury. And then this culminates in the pathology of a human spinal cord injury. This is now a chronic injury. So the hemorrhagic necrosis has been resorbed. There's a cystic myelomalacia surrounded by an astroglial response in the perilesional scar tissue. And then there's a retrograde and antegrade degeneration of these nerve fibers. So kind of seen in cartoon format, this is from a Nature Review article our group put together. So this is kind of the initial mechanical trauma. Again, there's a hemorrhagic necrosis, contusion, compression, disruption of neural tissue. And then there's early instigation of inflammation and proapoptotic signaling. And then the subacute phase, the first 2 to 4 days after injury, you start seeing this inflammatory firestorm, which has benefits in terms of repairing the injury, but also is sometimes miscalibrated and can actually amplify the lesion. And then in the intermediate and chronic phases, you have healing occurring, and the lesion begins to assume a chronic appearance at around 6 months after injury, with the formation of this perilesional scar, the cystic myelomalacia. There is a degeneration of the axons and some demyelination of residual axons. So one of the consequences that occurs that's of significant importance is a profound disruption of the sympathetic nervous system. And this results in significant cardiovascular complications acutely, specifically neurogenic shock, bradycardia, cardiac arrhythmias. Autonomic dysreflexia can be seen in acute phases, more commonly in the chronic phases. In venous thromboembolism can occur. So these are a lot of the very significant complications. So clearly, patients need to be transported to a unit that has expertise. This is a recommendation, and the guidelines would support this, and patients need to be actively monitored. Patients need to undergo standardized neurological evaluation, and what this means is the use of the Asia Impairment Scale and the standardized neurological classification of spinal cord injury, using the standardized motor and sensory examinations, and then delineating the motor and sensory levels, looking at the zone of partial innervation, and very, very, very importantly, always do a rectal exam, always assess perianal sensation. Sometimes patients can be incomplete, and the only way you can discern this is by assessment of residual pinprick sensation of the perianal area. It makes a big difference in terms of prognosis. So again, the hemodynamics is supported by very strong basic science evidence. Neurogenic shock is typically treated with an initial 1 liter volume expansion, and then quickly going to inotropes. And then this is supported by the guidelines evidence. This is now actually under review at the level of AO, Spine, and the Praxis Institute. And it's likely that there'll be some revised guidelines coming out later this year. There's a nutritional firestorm that's set off by any severe acute trauma, and acute spinal cord injury rivals very severe burns in terms of the impact as a hypermetabolic catabolic cascade. And the bottom line is that you need to institute GI feeding as soon as it's practical, certainly within 48 to 72 hours. And you need to amplify the caloric intake. And usually you're doubling it approximately in terms of what patients might normally require. And we all recognize that thromboembolism is a significant issue, and one should institute low molecular weight heparin as soon as possible, but certainly within 72 hours. So let's talk about surgery. So there's a strong rationale for early surgery. Jens and Chris Shaffrey and others will know the struggles, though, that we've experienced in terms of trying to bring this into clinical practice, the enormous pushback that we got on this concept. But there's really strong evidence now to support the role that early surgical decompression can mitigate the secondary injury. This is supported by basic science evidence. This is a meta-analysis of animal studies showing very convincing preclinical work to support this concept. And this was the study that kind of generated, I think, a lot of the controversy. This was collaborative work that we did through the Spine Trauma Study Group. See that Chris Shaffrey is involved with this, as is Jim Harrop. And in this study, we found that when patients with cervical cord injuries had surgery within 24 hours, in the mean time here was 14 hours, the odds of having a 2 or more grade change in the Age Impairment Scale was almost 3-fold higher. So it was a huge effect size. And I think that this study had a big impact in the field. There's been a number of studies now that have sought to take this forward and to replicate these data. And so this launched the first practice guidelines that came out 5 years ago now in Global Spine Journal, recommending early surgery as a practice option. And this is likely going to be further strengthened by a number of studies, including this one published by our group. This was from the Lancet Neurology. And I'll just take you through 2 of these graphs here. So on the left, these are the changes in the Asia motor scores as a timing post injury. And this red line is 24 hours. You see there's a steep dose response relationship. So really time is spine. And then these are the changes in the Asia motor scores as a factor of timing post decompression. And you see that the largest increases in the Asia motor scores are clustered in this first 24-hour period. So what do we see going forward? Well, there's going to be further knowledge translation, so you can anticipate actually during the course of your fellowship over the next year, there will be updated guidelines that will be examining this and likely strengthening the recommendations for the timing of surgical intervention. So is there a role for ultra early surgical decompression? It's challenging to do logistically. Sometimes the patients are pretty sick. There probably is a role, but it's also important not to mistake enthusiasm for evidence. And there is stronger evidence that's required here. There's interest in, perhaps doing a duroplasty, and there's a lot of enthusiasm around that. Is there a role for that? Well, there might be, but it needs to be studied. And there's a trial right now going on by Marius Papadopoulos and colleagues in the UK examining this. And what is a sufficient decompression? And how do we personalize the approach? And I think this is where postoperative imaging can be very important. So let's just talk about steroids. And this is important because this has been kind of bandied around. And I think some of the challenges have been that when the studies were first published, there was probably excessive enthusiasm. Then there was a realization that there were some complications, and there was probably excessive criticism. And we're now at a point now where I think we can reach kind of this middle balance. So this was an updated meta-analysis done by an independent group of people actually in Seattle. And Jens Chapman actually introduced me to this group. So this is a Spectrum Research people. This was done by Joe Dottori, who is one of the best clinical methodologists around anywhere. And this was a very rigorous meta-analysis of the literature. This is the forest plot. This is the bottom line. This triangle here, or this diamond, shows the mean improvements, 95% confidence interval. So it is statistically significant. The effects are around 4 motor points. And so clearly not all patients are necessarily going to get a functional impact from this, but patients with an incomplete injury, and particularly patients with a cervical injury, this could be quite important. You think about recovery of hand and upper extremity function. And then the other thing is that there were concerns touted around higher mortality rates with methylprednisolone, but the challenge here was that they were taking head injury data, and head injury has a completely different complication profile from spinal cord injury. If you actually look at the spinal cord injury data, and here's the mortality rates. The mortality rates are actually trending for lower mortalities. It crosses the 0 points. It doesn't reach statistical significance, so it's not statistically significant. But importantly, it's actually trending to reductions in mortality. So that's not an issue to be worried about. So I think the current recommendations here are that it's still a valid option, and you should, it needs to be left up to the individual physician and thinking about the patient. But I think this is an opportunity to personalize management. And if you ask me what I do use this in younger people, cervical injuries, incomplete injuries, and I think it's a valid option. So what's on the horizon? So the compounds here in parentheses have been studied, and have not been found to be effective. I won't talk too much about hypothermia, systemic hypothermia. This is being actively looked at the Miami Project to Cure Paralysis. But I'll talk briefly about riluzole. This is a sodium glutamate antagonist approved for use in ALS to reduce cell death. And we're looking at the repurposing of this in spinal cord injury. So I've just got a little video here just to kind of give you the idea here. So we're looking at cervical injuries. We're modeling this with a subaxial cervical burst fracture. So you've got the primary mechanical injury, the expansion through secondary injury mechanisms. So at the microstructural level, here are the nerve fibers. And then you've got sodium channels on the nerve cells. And then there's a rapid influx of sodium. There's cell swelling that occurs because water goes along with the sodium. And then there's calcium entry that occurs through reverse operation of sodium calcium exchanger. And then there's a pathologic release of glutamate. So if you can remember this, these are the critical mechanisms of so-called excitotoxic cell injury. These are the critical mechanisms involved in secondary injury. So riluzole is a cool drug because it directly addresses the primary mechanism in terms of targeting the sodium channel. And so we're looking at decompressive surgery and combining this with riluzole. So the patients are undergoing early surgical decompression, and then they're receiving a riluzole. So we did an early phase study. This was a phase 1/2A trial in 72 patients, 36 patients that received riluzole, and 36 controls. The control data came from the North American Trials Network data set. And we found encouraging data. So we saw pretty big improvements in the Asia grade changes and a very impressive improved trajectory of motor outcomes, particularly for cervical injuries. And so based on this, we launched the RISCUS trial. The number of people at this course who've been big supporters, Jens, Chris Shaffrey, Jim Harrop. We just completed the trial and we're now analyzing the data. I can't disclose that today because of embargo reasons, but we will be reporting on the results of this trial later this year and early next year. And just out of interest, we did publish last year in the Lancet Neurology the results of this randomized trial in degenerative cervical myelopathy with riluzole. We did not see positive changes in the MGOA, but we saw some interesting improvements in neuropathic pain and some other outcomes. And this is just kind of a brief shout out to systemic hypothermia, and this is being looked at in this registered trial at the Miami Project. So in terms of neuroregeneration, here we have the chronically injured cord. There's inhibitory molecules, scar tissue, loss of tissue that block regeneration. And so clearly regenerative strategies, I think, are going to be required for people with a very severe injury. And so cellular therapies have had some appeal in terms of potentially replacing lost cells, providing trophic support in terms of growth factors, in some cases providing immunomodulation. And so various cell sources have been looked at, but I'll briefly talk about neural stem cells, Schwann cells, and endogenous stem cells. So there's been a number of early phase clinical trials with neural stem cells. This is summarized in these two articles, one in Lancet Neurology and the other one in an ASNR journal. And we had the privilege of collaborating with a number of people, including Armin Kurt from Zurich. And the bottom line here is that the effects seen were very modest, probably not important enough to take forward at the current stage, but it was safe and feasible. And there's a lot of interest now in looking at next generation neural stem cells. And an example of this is actually from our own work published in Science Translational Medicine, where we can bias these neural stem cells to upregulate growth factors, such as glial-derived neurotrophic factors. So within your early careers, you are going to be seeing the translation of this into clinical trials. Now, what's cool is that the spinal cord itself harbors neural stem cells, and these are in the center of the cord. And we first reported on this in Cell Stem Cell about 15 years ago. This is beautiful work by Jonas Friesen at Karolinska, published more recently in Science, showing that in fact you can activate latent genetic programs in these neural stem cells. And it turns out that in fact, by modulating a family of glutamate receptors called AMPA receptors, you can actually upregulate these endogenous stem cells. Now, wouldn't that be cool if we could actually take advantage of the body's own ability to heal itself? Now, there's a couple of ongoing clinical trials looking at regenerative molecules. This is Armin Kurtz's translation of Martin Schwab's seminal work targeting the no-go receptor, phase 2/3 randomized trial in Central Europe. And they've actually just completed enrollment. So we anticipate that this will probably be announced in the next 6 to 12 months. And this is an ongoing trial supported by AbbVie Pharmaceuticals, targeting repulsive guidance molecule A, RGMA, which is an inhibitory molecule in the central nervous system that inhibits regeneration. And then this is an ongoing trial sponsored by In Vivo Therapeutics, looking at bioengineered scaffolds for Asia A thoracic cord injuries. A lot of interest right now in the concept of bypassing injured neural circuits with epidural spinal cord stimulation, enhancing locomotor training, rehabilitation strategies, and brain spinal cord interfaces. And I envision that there's probably going to be a new a specialty arising where people have dual training in functional neurosurgery as well as complex spine surgery to move this forward. So it'll be cool. So where are we right now in 2022? So I would say time is spine. Early surgery for spinal cord injuries become well accepted. It's challenging, and we need to look at implementation strategies and to personalize this. I think hemodynamic optimization is critically important, but we probably need to personalize this better. I think steroids do remain an option, and hopefully other neuroprotective options will emerge, perhaps riluzole. And I think there are going to be advances made in active targeted rehabilitation and potentially with epidural stimulation. So just kind of projecting where might we be in 10 years. So I anticipate that early surgical intervention for spinal cord injury will become the international standard of care. And there's a lot of efforts being made to try to implement this right around the world, including in low and middle income countries. Hopefully we'll have a number of neuroprotective options, and hopefully we'll be able to personalize the approaches to individualized care. We're just starting to understand the impact of genetics and genomics here. I think that we need to have methods to directly assess cord perfusion. And there are some early efforts underway with intrathecal catheters to actually measure interspinal pressures. And I think there's going to be a number of clinical trials that are going to be emerging in the next 5 to 10 years, looking at regenerative options. And hopefully some of these may show some effects. And I think that electrical stimulation is going to be the real deal. It's not going to work in everyone, but I think that this will be able to target certain patients. So on that note, I'll close out, and thanks again for asking me to speak at this wonderful conference.
Universal applause. Thank you, Michael. What a great big picture perspective with high detail resolution, nonetheless, in many different aspects. Let me pick up on one very tangible things. Since we don't have molecular cellular counter strategies available immediately, on a practical basis right now, this concept of early surgery is such a compelling thing. And if we look at vascular injuries, let's say a lower leg injury, a knee dislocation in the ortho world, with a vascular compromise, there's a clear standard that they have to go to the OR within 8 hours. If you don't release a compartment syndrome within 8 hours and the patient takes damage, which is highly likely, that's a clear, and in fact, in orthopedics, one of the leading medical legal causes of problems. This whole historical concept of early surgery being less than 72 hours and maybe 24 hours being revolutionary, when in fact 6 to 8 hours is what probably is the actual sweet spot, is still not a factor. So what can we do to kind of push this ahead? And is this kind of the immediately tangible next step that we could all agree on?
Yeah, so I think this gets to the concept of ultra early surgery. It makes sense. One of the points that we did in our Lancet paper was to actually show that there is a dose-response relationship between neurological recovery and timing of surgery. There's a lot of factors in terms of logistics that need to be taken into consideration to try to implement this. But I think as an important principle, time is spine. And I think that, there's nothing necessarily magic about the 24-hour period. We picked the time point because it was much earlier than what had previously been suggested. 72 hours, logistically feasible, is now become well accepted. But I would fully agree that when possible and feasible, one should try to go in as soon as possible. One of the challenges, though, that we will face, and Jim Harrop's going to be talking about central cord injury, is that we're seeing a shifting demographic with a lot of older individuals, incomplete and milder forms of cervical injury. And a lot of these people have medical comorbidities. They're on factor 10A inhibitors and things that make it challenging to go in early. And I think one of the messages that I would make here is that although it's optimal to operate within 24 hours, if someone is medically sick, you need to let the factor 10A inhibitor wash out. It's still acceptable to delay it a bit. And operating within the first few days is much better than not operating at all. Okay, and I think this is also going to likely going to be kind of lead into Jim Harrop's messaging with central cord injury, which is probably a term that is becoming less and less acceptable to consider.
One more question, then we need to move on to Jim Harrop, but this is fantastic. Michael, so you mentioned it quite well, but I want to just emphasize this to this group. So there's certain basic tangents that we all want to agree on now. And I think MAPS above 80 or 85 in acute cord injury are kind of, I dare say, almost a standard of care now. Is that correct? Whether it's intraoperatively or in a trauma setting? Is that a fair statement?
Yes, it is. Yeah, that's fair to say.
Now, let me hit on these steroids again. So we've gone from, during the NASCUS 2 publication era, from hyper-enthusiasm for steroids to the concept that steroids are dangerous. And when I poll fellows, I'm just going to ask our fellows here about this concept. Suddenly this thought is that steroids are dangerous. So no identifiers, show of hands again, digital response. That means your hand up or down. Binary response, all of you respond. Would you in an acute cord injury give high-dose NASCUS 2 steroids? Yes, raise your hands. No, raise your hands. Like 90+% would not want to give steroids. As you know, I'm a complete steroid proponent. Just to re-emphasize this point for education's sake one more time. Is it safe and could it be effective to give high-dose NASCUS 2 type protocol, so 24 hours or less, steroid methylprednisolone boluses? Yes or no?
Yeah, yes, bottom line. So particularly in cervical injury, so actually the complication profile is favorable, particularly in cervical injury. The complications are actually lower when steroids were given. And when we analyzed STASCUS, we had to actually control for the concomitant use of steroids, and there was an intersection effect between them. The challenge here is that there was hyperbole when the trial was published, and I think it should have been evaluated thoughtfully by guidelines groups and by organized neurosurgery, orthopedic surgery, spine surgery. So that was an error. It was way too enthusiastic. But the response now is all this emotional hyperbole against the use of steroids. And we now need to just look at this rationally. Like in neurosurgery, spine surgery, we use steroids all the time. For goodness sakes, if there is a drug where we do understand the complication profiles, how to use it, when to use it, what the problems are, we're going to understand how to use steroids. So if you've got a young person with a cervical cord injury, I mean, I don't know about you guys, I'm going to throw everything but the kitchen sink at this person. If I've got an 80-year-old frail diabetic, of course I'm not going to use steroids. It's going to cause problems and side effects, but we already know this, right? That's what I'm just suggesting. It's just an option for you to consider. What you decide to do, it's up to you. But that's my own view.
This is Chris Shaffrey. It was funny. I was can you hear me?
Yes.
Yeah.
Okay. I was at a NAS panel about 3 years ago, and there was again this discussion. Somehow I was put on the panel, and I asked the same thing, and 95% of a huge NAS audience of hundreds of people asked, "Would you regularly use it?" And not a hand went up. And then I said, "Okay, you're doing this cervical case where you're doing a posterior cervical laminectomy, and you drop an instrument." And you're monitoring people, say, "Oh my God, you've just lost all your signals." Who would give steroids then? And 100% of the audience raised their hands. And I think that Michael's thing about being thoughtful with it, and again, the emotion is different. And again, I think that, unfortunately, so much of what we do, we're open for criticism. You give something, you don't give something. I had an expert. I was involved in a medical legal case, and I had two of them within 6 months. And one of them, they had the same expert where somebody developed an epidural hematoma after surgery, and they said it's because you started Lovenox on post day number 1 and said you should never do it. Then 4 months later, I was at a thing where a person died of a fatal PE. They said, "Oh, you should have stopped. You should have given Lovenox beginning post-op day number 1." And so, no matter what we do, you can be criticized. But I think if you ask yourself, if it was you laying there, okay, what would you want? And I think the advantages of it are such that if I was laying there, I probably would want methylprednisolone and then NASCAS-2 protocol.
I am a bicyclist, and if I fall and I have a cord injury, I want a NASCAS-2 protocol, saying it, okay? I want to make this very clear. And just rationally, I'm just going to pop out what are the actual complications that were published in the NASCAS-3 trial, not 2, 48 hours. Wound infection rate, allegedly pneumonia, allegedly higher GI bleeds, maybe some psychoses. Am I missing something, Michael or Chris?
Those are the key ones, yep.
3 of those are eminently manageable with appropriate care. So, and again, the wound infection stuff, those were margins of percentage points. So I really appreciate that we have these main key opinion leaders, and we have more in the room here. We just don't have the time to sort this all out. Attend our spine trauma course, at least virtually, this winter in December to hear more about this exchange. We'll feature a larger panel again to sort this out. But I appreciate all of your responses. They were honest, and they echo what Chris said. But please reconsider and be thoughtful, at very least, to not be bedeviled by some people who are just nihilists. And we'll have one of the nihilists here, and John Hurlbert, who's a great person also. With this, we have to move on. Any other words of wisdom, Chris or Michael, to this subject?
Time is spine.
Wonderful. Let's make a t-shirt of that next year. We'll do that. We'll quote you and Chris on that. Thank you. Thank you both, and please stay on if you can, because the next speaker is not averse